Hello everyone, Peter Frampton here. I've been invited to give you a chat and I'm very happy to be here. Now, I have to say something. Michael and I did a dummy run of this talk last week, and fortunately for me, there was a technical hitch and I had to stop. But frankly, I was really unhappy with the talk. It was boring, it was dull. And the point is to this, that it was supposed to be interactive. I only had a few cases and we're gonna talk amongst ourselves. And of course, that's out the door now. So we'll have to sort of rethink how we're going to do this. And I think COVID-19 gives us a great opportunity. Although it's the problem, it also helps us because the gloves are off, if you will, and we can use loads of new things and learn by doing it. Because you know, you go to OPEC, you do your course, you go to OSCEs, you sit that. But does that really give you all the weaponry you need to face patients when they come in the door? Because they have a nasty thing of actually coming in, mucking up all your best plans. So what I want to try to do then is give you structure and give you some ideas on how to deal with these things. Now, at the bottom here is my website name, because we've been given permission to put this up on the web. So if you wanted to look it over again later, you can always go to that website and have a little look at it. So I want to give you structures really to try to help so that you can do things. So first of all, you've got to imagine, or you've got to think that your diagnosis is your working hypothesis, right? It's nothing better than that. Then you've got to come up with your clinical management plan and you've got to record your logic. And normally anyway, and especially under COVID-19, that may well include telephoning or faxing or someone another source, like a hospital source, and there's nothing wrong with doing that. And so you might feel alone, but actually you're not. Then you hit your treatment, you do your meticulous follow-up, and that's really important, and then you may adapt it. So you're allowed to fumble the ball, right? What you've got to do is you've got to pick it up and run with it, and if you fumble it, but you've got to have structure in there that you don't drop it, and we can collect everything up in enough time to help the patient, and we learn in the process, because that's how you do learn. Now, I want to give you an example of this, of me, and I didn't get anything right in this, right? That's the point. It's not about getting it right always, it's about having a go and having structure. So here's a patient of mine, this was last year, and he's a chef. His history says he's been having current erosions or current ulcers in the left eye. We don't know why, it could have been anything. He's not a contact lens wearer. And then he presented as an emergency on the 31st of July. A shard of ice had lacerated the right eye 3 days earlier. So he's a chef, he was chipping away at something and it went into his eye. Now, as he said at the time, it wasn't very sore, so he didn't seek any help. But then today, extremely sore, he self-treated with chlorphenicol. And that's what we saw. Now, the other thing to throw a curveball in on this, he was catering a wedding the next day, and therefore he had to be there. There was no plan B. Now, the question, I put this to optometry tomorrow a few weeks ago, and I said, who's going to refer and who's not? Now, it doesn't matter whether you're going to refer or not. The point is you've got to have logic to why you're doing it. Now, as far as I'm concerned, I had two big red flags that made me refer this patient and one logistical one. Now, at the bottom, I say before you pick a CIV category. Now, I haven't got to that yet. You don't know what a CIV category is. But what happened was, so think about it, but I know in the old days, we would all look at that and we'd refer. We all would. But you've got to think about why you'd refer. That's the logic to this. Now, of the group I was talking to at the time, 64% said they'd refer and 36% said they wouldn't. Now, so long as their logic's correct, both sides are right, but you've got to have a good reason. It's not just, oh my God, it's big and I'm scared and I want to refer it. That's not a good enough reason. So I hope you're going to think about that a little bit and figure out. Now, here's my logic. It appears as a large macroaneurysm, or a macroabrasion, I should say. But if it was, the abrasion would have felt bad when it first happened. It would not feel okay and then be really bad 3 days later. That doesn't make any sense. And what about the ice? What's the survival temperature range of acanthamoeba? Well, I'll tell you, it'll survive in the Antarctic, so it'll survive in ice. And if I treat, and the logistical one is, if I treat it as a macroaneurysm, macroerosion, I should say, which is what I thought it was, and review tomorrow and then had to refer, the wedding would be shot and there'd be no chance of finding replacements. So we discussed this with the patient, we talked it all through, explained why, and I sent him off to the hospital. Unfortunately, at the hospital that time, I don't know who it was seen by, but there was no culture, discharged, given chlorphenicol again and told to go away. Right, so in our outcome order, I thought, oh, well, I've really blown that one. That was a silly one. Then on the 8th, now this is a week later, he returns with exactly the same symptoms. And this time I see this, quite a small lesion. And it looks like a bacterial keratitis, but he's not a contact lens wearer. But of course, I'm thinking it could be an opportunistic bacterial infection. So I gave him mefloxacin at the time, and again, reviewed very, very regularly because the hospital at this stage had discharged. And finally, we're seeing this. Now, it's the subepithelial stuff that was really getting to me. And I've only seen 2 acanthamoebas in my career. They both were subepithelial like this. They didn't have the classic appearance that you might read about. So to me, that was enough. So I referred him back again and to find out what was going on, because I was that worried. Now, I wrote a letter out. I gave them nice, succinct points, I like to think, because you've got to remember these people are busy. They don't want to have to trudge back. And otherwise, there's a high chance that they'll just look at one acute episode and not think about the past history. So I did it. And this time, bang, yeah, I figured it was recurrent corneal erosion. Now, when this lovely person that looked up, really accepted my logic, really was a courteous person, but I was wrong. So obviously, the ice trauma had resurged the recurrent corneal erosion, and it was actually slightly bilateral. So that was great. So he's being treated now under the corneal specialist for that. So I got nothing right there in a way, but I collected up the pieces, I kept a review, and actually I learned quite a lot. Now, if this happened again, I still think I'd refer, because the ice would still be the major bugbear for me. So that's why I would primarily refer. So you don't have to be right all the time. Now, the other great weapon we've got is now liaising with the hospital. Now, we've always been able to do that, but it's wide open now. What's in the patient's best interest? And you've got to think yourself, does my clinical management plan differ in a significant sense from hospital one? And if it doesn't, just do it, is my argument. But now, if you're not sure, just ring them and say, in Northumberland, we have a specialist number now while COVID's going on, where we can ring them directly. I just did it this morning, just to confirm what I was doing. And you can do that. You say, right, this is what we've got. What do you suggest? And write that on your notes, of course. And then the other thing that I've already alluded, we've got to sieve things. Now, sieving is a process. We don't have to absolutely categorically decide what something is. You've got to just sieve it. And there's loads of sieves, but I come up with the little thing ditty. Is it degenerative? When you're looking at a corneal thing or an anterior eye thing, is it degenerative? It is infective? Is it trauma? Or is it inflammatory? And quite frankly, so long as you can put it in one of those 4, there's also neoplasia, which we'll come on to, but basically, if you can put it into one of those 4, you're halfway there to treating it, even if you haven't definitively diagnosed it. And what's really important is when you're doing this yourself, describe what you see. Don't hone in straight away on what you assume it might be. Describe what you see. And this is really important because ophthalmologists have said, when you ring, and they're happy for you to ring, when you ring, don't tell them what you think it is. Don't say, oh my God, I've got a corneal ulcer. There's no point. The ophthalmologist is going to have to try to make a diagnosis based on your description. So you're trying to paint a picture for the ophthalmologist to make a diagnosis. So you have to describe what you see. Now, here's an example. This happened to me personally. My patient has a corneal ulcer and it's bleeding. It was my day off. I was somewhere else. Now, when you just see that, you think, oh my God, what the hell's happening here? You know, with blood spurting out of the eye or whatever. It doesn't tell you very much. It puts the wind right up you, but it doesn't actually help you. So, please describe what you're seeing And at the time, our cameras were down, our anterior cameras down. I said to my colleague, I don't care how you do it, but get a photo of this. And so she used a mobile phone and she gave me that. Now, suddenly it's different. Suddenly it's nowhere near as traumatic as you thought. Now, CIV category, is it degenerative? Is it inflammatory? Is it trauma or is it infective? Now, based on what, it's not central, it's off the side, it's inflammatory. This woman's also a diabetic and she's under poor control. And you can see the sectorial hyperemia of the conjunctiva as well. So it's an inflammatory thing, but this time it's gone a little bit further than it should have, and the blood vessels have actually gotten in as well. So from an initial thing, my patient has a corneal ulcer and it's bleeding, to actually it's not really that bad. We treated it with antibiotics as cover, but basically we treated it primarily with a steroid, and it went away. But then she still has a lot of problems. So the other thing is what makes patients, what makes everything interesting, and this is the thing, it's a unique presentation. That's what keeps you thinking. They're never going to follow a textbook supply that you get from WOPEC. They're never going to do it. And what does the patient actually want? Now, here's an example. Now, when I did this last week, Michael said to me, he said, I wasn't quite sure why you had this in. This is a glaucoma patient. It's not about the glaucoma, it's about how we think. So you've got a patient, you've diagnosed it, brand new patient, you categorically know, you've done every test known to man, you know this person's got glaucoma and you're going to refer. Easy, right? That's fine. We all know we're going to do that. But then the patient declines referral. Actually says, no, I'm sorry, I've got serious family issues. I ain't going to the hospital. Now, this is real. This has happened. This has happened to us a few times. People will do it. So what are you going to do? Now, again, I asked, these were IP optoms, right? I asked them, would you refer anyway? Would you annotate your notes for your legal safety and review? Would you treat the patient with the patient's approval via the GP? I don't know. And 39% said they would actually annotate the notes for their legal safety and then just review for progress. Now, to me, that doesn't make sense, right? I can get the group, I guess, that said, I'm going to refer anyway, because they're going to say, I'm just going to ignore this idiot and I'm going to actually refer. But I can't understand. It's a progressive disease and they're not going to do it. Now, what could you do now, though? You could just ring the hospital and say, look, I've got a patient. This is the story. What would you suggest? And again, this has happened to us before, and they said, well, if not going to come in, just prescribe. You can also go into Medicines Complete and actually find the recipe for treating this. But I would still ring the hospital first. But you know, it's great stuff. You're interacting, you're doing things, you're learning as you go. And by talking to the hospital all the time, they're in the loop. You're almost a supplementary prescriber, if you will. And this is great. It's great to do. So I couldn't understand why people would choose not to treat. So here's another quickie. This is under COVID now. 8th of April, this was. Very itchy eye for 3 days. Getting worse, slightly light sensitive, but primarily itch. Lids are red and the eye itself is white. Now, the patient didn't tell me that. You've got to drag it out of them, right? Patients say my eyes are red, and what they mean is their lids. So you've actually got to say, is the white of your eye white? And is your vision okay? And if those things are both good, you know, you're on the right track. So what would be the CIV category for that? Now, the very fact that it's itchy, that the eye itself is white, unilateral, I'm saying to this patient on the phone, it sounds like an allergic reaction, but please send me a photo. So there's the photo. So I've been doing this a lot lately, and it's great. They just get the phone out straight, send it straight down, you look at it, then you ring them back and say, this is what we're going to do. Now, to me, that looks like a contact type dermatitis. It's itchy. It's not very severe, actually. So I was wondering whether just to leave it, to be honest. And I said, look, we could put in some antihistamine drops maybe. And then I did mention hydrocortisone cream. I wasn't really going to do that because I thought, well, it doesn't look that bad, really. So I thought, no. But I explained to the patient how to use hydrocortisone cream. If you ever do it, it says all over the bottle, don't stick in your eye. Right? So you've got to make sure the patient's in the loop on this. You say it's not about the eye, this is about the lids. And you've got to keep your eye shut and lightly dab it just on the lids. And the patient actually did that. They were down the street anyway, or his wife was, and they got the hydrocortisone cream. And I had a lovely email back the next day, or the same day actually. Thank you very much for the advice this morning. It's working, and my eye feels great. So all that over the phone, but basically talking to the patient and putting the patient in the loop as well, incidentally. So, right. Now this one doesn't need sieving, does it? This is one of those rare ones that we can actually go straight to the killing point and say, yes, this is a viral simplex keratitis. So it's not hard. What's your clinical management plan? Now, just say we're under COVID. This patient has sought you out, has come out into the community and is sitting in front of you. They don't really want to go all the way to the hospital as well if they can possibly help it. So what are you going to do? Now, you can actually go, well, in Northumberland, I've got access to the eye emergency department protocols. Now, you will have eye department protocols as well. And I actually have them on my website as well. And it tells you to treat this because it's definitely just dendritic, it's just epithelial. Ganciclovir 5 times a day for a minimum of 2 weeks, no follow-up. That's what they say. Now, if you don't have access to that, well, actually, if you don't have access to your eye emergency department protocols, you can actually get them off my internet site, right? You go under education, you look at training manuals, and you can look it up. Now, that's obviously not necessarily the one that's in Northern Ireland, but it's probably pretty similar. But the other thing you can do, of course, is just ring your hospital and describe it properly, explain what it is, say the patient's not very keen on going through the hospital at the moment because of COVID, they're 75 years old or whatever it might be. Now, the only thing I'll bring up is no follow-up. You've got to appreciate that hospitals are really busy. We're not that confident. I'm certainly not that confident. I would never allow a patient to not follow up. I would either, under COVID, I would perhaps ring them, but I would certainly follow up because until I know that's finished and nailed and the patient is happy, I won't let them go. All right. So you've got to go with your own level of confidence and competence, but obviously the hospital system is very confident and very competent, and they go with no follow-up. So this is a really interesting thing. Under normal conditions, that's textbook. If you read that in textbook, yeah, you wouldn't think much about it. But if you did that, you've really pushed your envelope, and you're never going to work the same again. You know, once you've tried this out, thought, my goodness, I can actually physically do this. I can pull this off, and I can help the patient, really help it. That's really good. It's a great feeling to do, and you really get confident fast. So here's an easier one, I guess. Contact lens wearer, emergency appointment, 24-hour history, left eye only. Now, I'm telling you flat now, the cornea is clear as a whistle, right? You put the fluorescent in, it's absolutely clear. Vision's excellent, right? So you don't have to worry about anything. You can muddle this around all you like. It's not going to come to any great harm. He rubbed his eyes, felt a bit uncomfortable yesterday, removed lens, vision's excellent. Do you have a specific diagnosis? Do you need a specific diagnosis? What's the CET category? Now, okay, normally we'd have a bit of chat about this. It's inflammatory, that's chemosis. Incidentally, chemosis and papillae are flip sides of the same thing, right? It's the innate immune system blowing up. But on the bulbar conjunctiva, there's no tight bond, so it just blows out like chemosis as opposed to papillae, but it is fundamentally the same thing. So if you did nothing with this person, it would go away by itself. When these people come to me, they're paying me money, I like to treat it. So I treated this with FML. What I'm suggesting to you, this was a type 4 allergy. He obviously, without knowing it, the trigger, I have little doubt, was something that he touched, and that caused this blowout. But we nailed it dead quickly. And here's another quickie, which same sort of thing, only this time it's bilateral. The secret or the clues are in the history. Unscheduled appointment, bilateral, had false eyelashes attached, and it's been growing since then. So it was a delayed type 4 delayed hypersensitivity reaction. With all allergies, what you're dealing with is inflammation. It might be triggered in different ways, but it's basically inflammation. So the same principle. The cornea is clear, always clear. Put the fluorescent in, that's fine. Again, what did I treat it with? Obviously, I treated it with a steroid because I like doing that sort of thing. The GP had prescribed some systemic antihistamines and Opticron, which you could do, but of course, you've got to tell the patient it ain't going to work very quickly. This young lady, if you imagine someone's putting artificial eyelashes on, obviously she didn't want to walk around with bright red eyes. She wanted a prompt resolution. So I treated it with a steroid, soft steroid. So another quickie, Friday the 24th. This is Monday the 27th when we're recording this. This was last Friday. Left lid tender, red for 2 days. Rang the GP and the hospital eye service, both declined examination. Vision's good, but when she touches it, it is painful. And so I requested an upper face photo. So again, when you're doing it, I always ask for both eyes so I can see that they're not the same, and then the affected eye. So you get a close-up of the eye they're talking about, but you get an overview of both eyes to see that if there's any similarities. And this is what we got. So it doesn't look very bad again. And I was in two minds whether just to say, look, let it go. You know, it's not going to be too bad. But it was painful to palpate. It's very close to the duct. So I was a bit concerned. And one thing I can say, well, I'm comfortable that's an infection because it's really tender to touch. And it was Friday. So I thought, do I wait till Monday and see if it's just got better by itself? But what I decided to do is actually prescribe some coamoxiclav via the GP. So I wrote the letter out and I emailed it directly to the doctor's surgery, and she got it straight away and she's been taking it. I obviously found out for sure that she's not allergic to penicillin. Now, you know, if you left it, it would probably go away by itself, but it is tender, so that's why my diagnosis or my idea is that it's infective, not actually inflammatory in this case. And just this morning, she sent me a lovely email saying, thanks to you, the doctor and pharmacist, we had the medication within 3 hours and it's all starting to get better. So hurrah! So, you know, these things we can do. If I'm gabbling, I'm sorry, go over it again. So this is a far easier one. That other one was tricky because it's subtle. This one, absolutely classic, right? Now, I make a declaration there. This is not the patient I was seeing. These are pinched off the internet, but that's what it looked like, right? There was definite pus coming out of the puncture and it was swollen and tender. So sieve category, well, we're all going to say this is dacryocystitis, I know that, but the sieve category is it's infective. So we're going to treat or whatever. Now, okay, under normal circumstances, you'd refer that. If you're not IP, I get that. But actually under COVID, you know, you could say, well, I want to try this. And again, you could ring them. And if they say, this is what I would do, you write that in your notes and you give it to them. And you're safe as houses then, right? Absolutely safe as houses. And the College of Optometrists clinical management guidelines are great for this. And they say, for mild and non-febrile cases, consider prescribing, right? Now, this is it. You've got to have your red line. You've got to think, right, this is a perfectly healthy human being. She's really fit. She's not got any systemic problems. She's not got a fever. It's just that one little thing. Now, if you had any red flags, if she was feverish as well, you don't do what I've just done, right? You refer them. But so long as they're non-febrile and happy and comfortable in themselves in others, and so long as they're involved in the process, there's no great hardship in actually doing it. Again, if you ring the hospital up, they'll tell you again. And so I prescribed coamoxiclav and it went away magnificently. I then, though, there had to be a reason for this, though. I then was going to write and get it sorted out because I figured she needed a DCR. So write a succinct letter there. Well, not that succinct, but you know. But I did actually have to keep prescribing because as soon as she stopped the coamoxiclav, it actually kept coming back. So we kept repeating the prescription for a little while until she got seen at the hospital, and she's since then had a DCR done. So that's a nice, easy one. When they're that gross, if you will, the decisions are really easy. It's these really subtle ones where you think, is it this or is it that? Then you've got to sort of make harder decisions. But it's an interesting life and it's good fun. And so long as the patient's involved with the processes, it's absolutely fine. If the patient says, I don't like what you're saying, I'd rather go to the hospital, for heaven's sake, send them to the hospital, right? Don't take it on. But if they understand you and trust you and you've incorporated them in the process, it's actually great. It's great fun. So now this is a classic for a PEARS service, right? This patient, emergency appointment, 2-week history of red irritable eye, right eye only, he says. The GP prescribed hypermellos and chlorphenicol and no help at all, and the nurse sent them to me or you. Now there is a classic PEARS thing. That's exactly how it's going to happen, I think. And then you're going to look at that and you say, right, what am I looking at here? Now, I'm going to suggest to you in this case, there's an acute CIV pattern and there's a chronic CIV idea. I think in an acute sense, this is inflammatory. You can see the green. We're legally allowed to use lissamine green again, incidentally, so it's okay, right? They're raised and they're clearly inflammatory. The cornea is absolutely clear as a whistle. I'm calling that limbitis. I can give it any name you like, really, but I'm calling it limbitis. But then you look at the other eye. And this is the same mistake I made earlier on with that recurrent corneal erosion. You know, he had signs in the other eye of recurrent corneal erosion as well, but I was so fixated on that huge abrasion, I didn't think about the other eye. Now, if you look at the other eye with this chap, both lids are pretty dodgy. They've lost a lot of tone, they're lax, they're cicatrized, they're not in good shape. So his tear layers are rubbish. And so in fact, he's got a lot of inferior corneal involvement in both eyes. So basically, again, for the acute episode, I treated with fluoroquinolone, fluorometholone, which is a very soft steroid for the limbitis, got rid of that, but then wrote a letter to the doctor saying that we need to do more on long-term chronic care for this gentleman because the lids and the tears are in very poor shape. So we talked about lid options and all the rest of it. He's the sort of bloke that won't do that, I have to say. He's going to keep coming out with acute episodes, I think. But you've got to look at both eyes anyway. Interesting cases, they're a doddle really, but as if a newly qualified optometrist looked at that, I'm not sure they actually know exactly what to do. But if you sieve it down, it's inflammatory. The trigger might be more a degenerative thing, but the actual presentation you're seeing is the inflammatory one. But then there's the chronic degenerative changes with the lids that we have to deal with as well. Right, 55-year-old lady, new to your practice, flexible wear, presbyopic contact lens wearer, sleeps in the lenses 4 times a week. She's an internet purchaser and she has no regular aftercares. New to your practice. Got right. So what are you going to make of this? Is this degenerative? Is it infective? Is it trauma? Or is it inflammatory? Now, I don't know. It'd be nice to have this conversation because this is a tricky one. So, history of very painful right eye this morning. Blurred vision, was hoping it would go away, but didn't. But she did have trouble taking her lens out this morning. So, this is trauma. And you can tell that really by the sharp edge on the lower part of that. This lady has fundamentally pinched this off. And again, it looks, because it's big, it gets everyone a bit, oh my goodness, what am I going to do with that? But when you really think about it, and of course, the contact lens stuff's all a bit of a red herring. Okay, she was living in Spain. She reckoned she had to buy them on the internet there. I don't know how that works, but you know, it's not as bad as it looks. Now, I hope you all looked at that and looked at the sharp edges and however, and decided that this is trauma. So again, we just gave her some chlorphenicol ointment for prophylaxis, and it was gone in 24 hours. So reviewed in 24 hours, of course, meticulous follow-up. So I'm sure at a hospital, they just tell her to go away, but you want to be safe, and it resolved very, very promptly. So 4 cases here. First of all, I'll do a quick quiz. Of the 4 patients below shown, which one may not report significant pain? So let's go through them. That's just a quick quiz to at least make sure you're still awake. I'm just blathering on. Now, first of all, let's go for a SIV category. We're all of them. They're all trauma, obviously. The first one, bottom left, is a child's nail. And they're really, really, really painful, as you all know. Now, what are you going to do with that? Well, you're just going to give chlorphenicol again, I suspect, and just watch it the next day. That should be gone the next day. But spectacularly painful, and I'm sure you all know that. You don't need me to tell you that sort of stuff. But, it's a classic child's fingernail slash down the cornea. The only thing I would add to it was, I think with these sort of cases, you should say to the patient, there is a likelihood that there could be longer term issues coming along, epithelial basement membrane disease or dystrophy or disorder, because the epithelium's weakened and you do have that classic on-waking sensation of real severe pain. Now, the bottom right, does everyone recognize that? That's Siedel's sign. So this person's had a penetrating, I've only done one of these ever in my life, a small child that stabbed himself in the eye with a pencil. And you put loads of fluorescein in and you see the pooling of the aqueous coming down through the fluorescein. And these people, this young lad was not in really any pain at all, because it had gone way past all the nerve endings. It had gone straight through. So this person wasn't really in any pain at all. Walked in upright. I put the seat. We rang the hospital. They were all waiting for him. He felt really. His name was Aaron, actually, and he was proud as punch. Now the other 2 though are patently foreign bodies. Now I don't know how many of you are bothered about foreign bodies. They can be. It's a psychological thing, I think. Right. Now, this is the way I do it, right? And you don't have to dive in feet first with a bloody great needle, right? You don't have to do that. One of my first things, I don't use cotton buds. I use the blunt end of a fluorette, and I find that extremely handy. And I can get rid of probably 80% of my foreign bodies just with the blunt end. And, if you think about it, you could stab them in the eye with that. You're not going to do them any harm. So it's a good way to start doing foreign bodies without picking up 25 gauge needles. Right? Now, both of those, that top right one there, or top left one there, it was just underneath the lid. That almost just dropped off. The one on the other one is obviously a metal one. And again, I got most of it out with the fluorette. Sadly, sometimes then they leave a bit of a rust ring, and that can cause a little bit of trouble. And that's when you might want to move on to other things. There's my little contraption there, which you've got to be careful with these things, because if they get a soft edge of an epithelium, they'll whip the whole thing off. So you sort of end up with a sort of a blob of epithelium on the end of your thing. But I sometimes use that just not turned on, because if you look at it very closely, it's not a burr, it's got tiny little spades on it, and you can sort of dig around. But the 25 gauge needles, that's when you start coming in from the side and just doing it. But honestly, if you're nervous about this stuff, don't even think about that. 90%, like I said, 80, 90% of what you have to deal with can be done with the blunt end, the square end of a fluorette. Now, we all have our different techniques, but I think as a beginning thing, if you've not done them much, or if you've never done them before, it's a scary thing to go approaching someone with a damn needle. So I do recommend that technique. That's how I started, and then I moved on and I thought, yeah, this is easy, I'll keep going. Now, no quizzing this time. Has anyone seen, and can everyone identify negative staining? I don't think they're still not taught this at uni. I don't know. And what are the symptoms and what are likely etiologies? Now, it could be either degenerative or trauma. And so you put your if you haven't seen it, you put your fluorescein in and you wait for it to pool away a bit, and you see this convoluted type pattern of stuff. And it's because the epithelium, it's raised a bit and it's a bit undulating. And it's often the only sign you'll see. The symptoms are, oh my goodness, every time I wake up in the morning, it's really, really painful. Now, if it's bilateral, it's usually a degenerative thing, it's EBMD. If it's unilateral, it could be post-trauma, like that child before, or that person before who had a child's nail slash their cornea. They could well have this later, but it would just be in one eye. And so the treatments are usually just to give well, Xalin, say, every night in the eye to help the epithelium bed down more, or you can refer, if it's really bad, to have punched stuff from the ophthalmology department if it's very, very bad. But I don't know how many of you know it. If I was looking at you, I'd be looking at either nodding heads or blank faces, but unfortunately that's the way this is. So how much time we got? Yeah, a little bit. So here's one. Post-cataract review. Was extracted 3 weeks earlier. The lady is 97 years old. The eye that was done is not very good. Vision's rubbish. That's the right eye. And the eye feels gritty and blurry. And when you look at the slit lamp, that's what you're seeing. And she reports, her son is with her. She reports she's been unable to instill the drops. So she's not been getting almost any steroid drops in her eyes. She lives alone. Family members work and live 50 miles away. Her routine check that I was supposed to be filling in the audit form for is not due for 2 weeks. So this goes anytime, but what about now? She's not even going to get a damn review, is she? Because she's in lockdown. But you think, what's in the patient's best interest and what can I do? Now, think about it. What would happen if I referred her to ophthalmology? They'd simply re-prescribe steroids because that's what the steroids are for, because this is inflammatory post the trauma of having a cataract out. We all know this. We see this all the time. So you know what they're doing. So just prescribe them yourself. Again, you could ring the hospital, and I did. I rang iCasualty, confirmed the dose, because I decided to give Pred Forte every hour while awake. They suggested every 2 hours, I think, but I decided, well, with the chance of her putting them in, and we gave her a lesson taking we coaxed the son to be a bit more interactive with his mother, and he decided that he would help a bit more because he was slightly stroppy. And it all went well. And then I wrote the letter to the doctor to say about it and explained that we gave her the first dose of drops out of my dispensary because we're independent prescribers, we've got it. And then I got the doctor to keep prescribing it until she got to see her checkup, or have a checkup in a couple of weeks' time. Because, you know, really, do you want to send a 97-year-old 40 miles to a hospital to be given what you know that they're already going to get? But again, I rang anyway. As an IP, I thought, no, I'm going to check this. Talked to an ophthalmologist as well, wrote it all down. Actually, I didn't talk to an ophthalmologist. I talked to another IP optometrist, a chum I know. So it was interesting. So we had a nice conversation and we re-prescribed steroids. Why not? We can all do this. So 50-year-old female, general health good, no medications, right eye aching several days. I'm telling you flat now, it's iritis. Okay, we've got flare in the anterior chamber there. Other information, I'll just rip through this to get to the next bit. Other information prior to considering your CMP. Now, under normal conditions, you're going to refer this, I get it, unless you're IP. Her general health is good. She's not on any medications. These are important points. And if you were ringing the hospital, these are really important points. This is the first episode. It's monocular, but she does have lower back pain. So it's a acute episode. Because of the lower back pain, I ordered in some other tests, and I straight away gave Pred Forte. And the way I do it is it's every hour for a week while awake, every 2 hours for week 2, 4 times a day for week 3, twice a day for week 4, and once a day for week 5. And I ordered in some other tests. How did I know about the other tests? I'll show you. I do know about HLA-B27 because the lower back pain made me think a bit about ankylosing spondylitis, but that was just me. But you could ring them and ask. So this is the beautiful thing now. You've got the patient with their iritis, you've got your optometrist, your GP, and your EED, your emergency eye department. So you explain to them, it's unilateral, it's acute, it's the first episode, they're fit and well, but they do report the lower back pain. Now, Medscape. If you ever want to look this up, this is a phenomenal resource. You have to register with them, but it's free and you can just look it up and it's great. And it tells you if a first episode and there's no red flags, you treat the acute episode. By the third episode, you start calling in further tests because you start to think if this person's having an idiopathic iritis regularly, maybe there's something else going on. Obviously, this is after you dilated the pupil and looked at the back of the eye and all that as well, obviously, right? But then you look for red flags. Now, for instance, if someone like this walks in, this is logical. You don't have to be taught this, right? It's just logic. If they walked in with bilateral, you're not going to touch it with a barge pole. I mean, what are the chances of someone having bilateral idiopathic acute iritis at the same time? It's just not going to happen. So that you'd think there has to be something underlying it. You might treat the acute episode, but you have them off fast. And are there any systemic red flags? Is the patient well, or does that patient have chronic inflammatory problems? And also, obviously, if it's granulomatous, unless you're convinced that they're really old, they're off. So just by using logic and ringing the hospital and doing things, they might be telling you just to treat like this. And it's really interesting stuff. I love doing this stuff. It's great fun. So here's another one. Now, this is getting trickier. How much time we got? I might make this the last patient, I think. Using our logic, 64-year-old woman, the eye is completely comfortable, but the right eye's gone hazy and it's getting worse, and she's going on holiday tomorrow. Now, her full history, and this is really important, in 2005, we referred her for zoster keratitis, and she's been under the hospital ever since. Her next review is not for 3 months, and her current medications, okay, you've got those systemic ones there, but her current medication is Pred Forte, 1 drop per week, and she has no meds for IOP. Right, so what's your CIV category? Does anyone immediately think, oh my goodness, I know exactly what this is? Now, the clue, whether you know your five sorts of simplex keratitis or not, whoops, it's going to be inflammatory, isn't it? Because the hospital's already treating them with Pred Forte. Pred Forte is an anti-inflammatory, so I think we can pretty much assume it's inflammatory. So my working hypothesis is this is interstitial keratitis. And if you remember, I always remember IK because it's inflammatory. It's an immune reaction to viral antigens. So IK, immune, right? So it's inflammatory. It's never very painful. The eye is basically white, actually. It's just that the whole stroma is hazy. And so what's in the patient's best interest? They're going on holiday. She definitely does not want to travel to the hospital. So I simply increased the dose. I didn't tell anyone, I didn't talk to the doctor. You could if you want to. I didn't in this case. I boosted it up and reviewed the next day before she went. I tapered it over the 2-week holiday period, and she was within contact. She was only going on holiday in Britain anyway, so she could have got back to me fairly quickly if she needed to, and we monitored the IOP. And at the moment now, she's back to just putting it in twice a week. So the thing about immune interstitial keratitis is these people are on chronic care. It's never going to go away. And as soon as you stop the steroid, it all flares back up again. But of course, the only way you know the minimum dose possible to give is effectively to overshoot it. And that's what happened. They tapered right down. They thought 1 drop a week was going to be just enough to keep that inflammatory process under control. It wasn't. And now she's on twice a week. But it was easy. It's easy. So long as you've slotted it down, and then you can go to your Medscape afterwards and look it up and learn it again and reacquaint yourself with the 5 processes that could happen, and you're happy with it. But the clue is all in the pre-history. You know, what's already been happening. All you're doing is not changing a treatment. You're just, well, you are changing the treatment, but you're just changing the mode. So what's this one? If I showed you that, and then we'll stop. If I showed you that, what would you say? This is logic. Now, I reckon a lot of people might say that that's some sort of neoplasia. If you saw both, though, and said, you know, both lids are rubbish, you've got those ulcerative things all over both lids, suddenly that might change what you think. So a single one of those erupting, you might think of basal cell carcinoma, perhaps. Or a sebaceous gland carcinoma. But actually, when you see both lids are like that and both corneas are pretty rubbish as well, this is actually ulcerative blepharitis. And you treat appropriately. I treated with an antibiotic, systemic antibiotic, doxycycline. But again, I'm trying to get across the fact that you look at everything, make some interpretation, and use your logic. But I reckon that might be about 50 minutes now. And I think you might all have a lot of questions for me. So if you're all happy with that, I'll leave it at that. I know I blathered them through and it wasn't the way it was supposed to go, but I hope you enjoyed it, and I'm always available for talks. Thanks very much, everyone.